today is very interesting, and it is also very important because it gives us our daily bread and butter. But of course, if the gynecologists get too greedy, then their hysterectomy rate starts going up. But jokes apart, at least 1 in 5 women over 40 will have an episode or will experience abdominal uterine bleeding at some point of time in their life after 40. So this group actually comprises of two very distinct women groups. The perimenopausal, which is the over 40 years women, but who still haven't attained their menopause, and women who've gone through their menopause, technically who have not had a period for last 12 months. So we will take these separately because the management differs a little bit in both these groups. Abnormal uterine bleeding could be, the commonest is menorrhagia. Intermenstrual bleeding, in fact, gives a higher risk of endometrial cancer than menorrhagia. Then it could present with postcoital bleeding or with postmenopausal bleeding. So first, we start with perimenopausal women with abnormal uterine bleeding. So this is known to everybody, and I'm not going into details, but this was the FIGO classification, which was published in 2011. And this palm coin actually gives the causes of perimenopausal AUB. The palm gives the structural causes, and the coin gives the non-structural causes of abnormal uterine bleeding. So what are we worried about? Well, blood loss. It's a lot of nuisance value, but also it has great impact on the quality of life. If not taken care of, it can cause chronic anemia. So we need to stop this excessive blood loss. But even more than the blood loss, as we get older, we are worried about, do I have endometrial cancer? What investigations we need to do in these women who are 40 plus, but yet not menopausal? So we need to do a full physical exam, including per abdomen and pelvic exam, a full blood count, primarily to look at their hemoglobin. FSHLH does not help manage these patients, and so it's not required, need not be done. TSH, nowadays we have started doing almost for everybody who comes with abnormal uterine bleeding. There's no harm because we know that if the TSH is little raised and if you give a little thyroxine, then risk benefit, there is no risk. So people feel that it might do some good giving a little bit of thyroxine. But there is no universal recommendation to do TSH or to look for thyroid function in asymptomatic women. Of course, the most important investigation is pelvic ultrasound. We prefer to do transvaginal scan, but if the uterine size is big, then sometimes you need to combine both transvaginal as well as transvaginal. Then the last but not the least is endometrial sampling. Should it be done with or without hysteroscopy? And the first question is, do we actually need to do endometrial sampling for all premenopausal women over 40? So in this slide, I have actually taken up views of different authorities, different societies. There is no consensus on the cutoff age when endometrial sampling should be done. If you look at the Canadian Society of Obs-Gynae, they in fact recommend endometrial biopsy for all cases, even below 40 years. If you look at the American College, then
Dr. Deepa, please mute yourself.
In women more than 45 years, endometrial biopsy is recommended for all by the American College. But in less than 45 years age group, it recommends endometrial biopsy only if risk factors are present, or if the woman is having intermenstrual bleeding, or if she fails to respond to medical therapy. NICE guideline, which is the most recent out of all these, does not recommend endometrial biopsy in premenopausal without risk factors at any age. And it goes on to add that if you do have to do a biopsy, it should not be done a blind biopsy, and it should always be in the context of hysteroscopy. So it should be combined with hysteroscopy if a biopsy has at all to be done. In low-risk women, endometrial biopsy what should be the cutoff or what should be the indication again. So this was a Canadian study. And I can just add a little bit here to give an idea about the incidence of endometrial cancer, that the maximum incidence of endometrial cancer at the moment is in Canada, US, and Western Europe. And if you compare this to Indian statistics, then these countries have almost 10 times the incidence of endometrial cancer as in India, although the incidence is growing worldwide, India and abroad. So endometrial cancer is the most common gynae malignancy in Canada and US and has a lifetime risk of 3.2%. Anyway, this study, they had 209 women with abnormal uterine bleeding between 41 to 50 years without any risk factors. They excluded women with risk factors except nulliparity. And they found that out of these 209 women, 2 had hyperplasia with atypia, which actually resolved without treatment during follow-up. 3 had hyperplasia without atypia, and they did not find a single patient with endometrial cancer. And when they divided these women into 2 groups age-wise, 41 to 45 and 46 to 49, then they found that the incidence was similar because they had 1 patient with atypia in each of the group. So they concluded that the risk of cancer in premenopausal women without risk factors is extremely low. The risk factors being persistent intermenstrual bleeding, nulliparity, obesity, diabetes, hypertension. Lynch syndrome significantly increases the risk. Like if you say the lifetime risk for general population is 2 to 3%, with Lynch syndrome.
Ma'am, just a minute.
Yeah.
Dr. Anurag Bhatta, please kindly stop sharing. You are interfering with us, with our presentation. Thank you. Ma'am, आपको re-share करना पड़ेगा.
अच्छा, okay. इसमें कोई तरीका नहीं है ना, citing that these are the risk factors which we all know, which increase the risk for endometrial cancer. Lynch syndrome, by the way, is a very significant risk factor because I was telling you that the baseline population risk, if it is 2 to 3%, with Lynch syndrome goes up to almost 50%. So that's, it's not that common in India, I suppose, or maybe we are not testing it, but that is the statistics. So how do we treat these women with abnormal uterine bleeding in the perimenopausal age? So pharmacological treatment can be started even before investigations. You can give them tranexamic acid, which is a very good hemostat, which can be used with alone with other drugs, does not interfere with hormonal treatment. You can give them NSAIDs. If there is no pathology identified, if fibroids are less than 3 centimeter, not distorting the cavity, or if there is suspected or diagnosed adenomyosis, so basically there is no gross pathology identified, then the first line should be to consider LNG-IUS. But if the patient refuses or does not wish to have LNG-IUS, then you can go on to standard hormonal treatments, which we have been given for so long. Combined hormonal contraception or cyclical oral progestrogens can be given. In second line, you can also offer them endometrial ablation or resection. So nowadays, we have got a number of second generation endometrial ablation techniques, the balloon therapy and many others, which are very simple to use, do not need much learning curve. But of course, somebody like me who has grown with endometrial resection, I still prefer to do an hysteroscopic resection or ablation, because to me, I feel that these procedures, that's the downside, although they have a lot of plus sides because they're very, very simple, the second generation ones, but they are blind procedures. So to me, I feel that, you know, if you are trained, then you should maybe go for these procedures, hysteroscopic procedures, where you can actually see exactly what you're doing. So this is a short clip for transcervical resection endometrium. The way I was taught that because the fundus and the area near the cornu is the thinnest, so you do roll a ball in those areas, and then the rest you can do either ablation or resection. Resection gives you a little higher incidence of amenorrhea. What about if you have fibroids, bigger fibroids, more than 3 centimeter or submucous fibroids? Then you could still try the standard pharmacological treatment, as I said before, like tranexamic acid, like hormones can still be tried, because even if you see the fibroid, doesn't always mean that the fibroid is causing the bleeding. It might still be the endometrium, and they might still respond to the standard hormonal treatment. But if they don't, then if you think that the fibroid is the culprit, then you can either go for uterine artery embolization, or you can give ulipristal acetate. Ulipristal is a very useful drug. I have used in few patients, but the effect is dramatic. I found it very useful. I've saved a few hysterectomies with ulipristal. You do have to explain a little bit about the liver injury, and the recommendation is that you do liver function test before starting, and every month. Each course is for 3 months, then you give a break for 1 month. If required, you can give up to 4 courses. Something which I've said earlier in some meetings, that once I was presenting on ulipristal, and I went into great detail of literature search, and I found that European Medical Agency, which is an agency in Europe, which is to do with safety of drugs, like FDA, they had actually said that ulipristal is much safer than many of the common antihypertensives we are prescribing every day without any monitoring. So just because we've had a few patients with liver injury does not mean that it is a very unsafe drug. So it can be used in selected patients, but you do have to tell the patient a little bit about liver injury. So you can do myomectomy, and myomectomy could be open, lap, hysteroscopic, whatever. So if it is a type 0, 1, and some type 2, it can be tackled still hysteroscopically, then you can do a hysteroscopic resection. There are even trials where head-to-head people have done lap myomectomy versus hysteroscopic myomectomy in 2 sittings for type 2 myomas, and still found that the results were better with hysteroscopic myomectomy. It has its own advantages because you go through natural passages, so it's like a natural orifice surgery. So this is a fibroid which is on the anterior surface of uterus, and this was actually a radiologist who came from Bathinda, had very severe menorrhagia. In fact, if you remember, like our older gynae books used to say, I've forgotten now, like Shaw used to say something, that if you have very heavy bleeding, you're more likely to have a submucous fibroid than have an endometrial pathology. So coming to postmenopausal bleeding, how is the risk of endometrial cancer? Because obviously, as you come to postmenopausal group, the risk of cancer increases, and we are all worried. At the maximum concern is about not missing a cancer. So this was a study where the incidence of endometrial cancer was seen in women with postmenopausal bleeding. They saw that overall incidence was 8 to 11%. So roughly you can say 10%, and you will say 1 in 10 women with postmenopausal bleeding can have cancer. That's a statement that you can make very, very clearly. So, but if you look at the age, among the postmenopausal, the risk increases as you get older. So less than 50 years, it is less than 1%, even in postmenopausal women. 55 years, it is 3%. And then it slowly creeps up to 25% by the time the patient is 80 years or more. So the overall risk increases, although generally as the age advances, these cancers are not very aggressive. So that is a good thing. Majority are diagnosed in stage 1. Unless the patient is not coming for help, they can mostly be treated in stage 1. What are the causes of postmenopausal bleeding? So polyps, endometrial atrophy, endometrial hyperplasia with or without atypia, and endometrial cancer. Now, most studies, when you see on the net, you find that endometrial atrophy is given as the commonest cause of postmenopausal bleeding. But somehow, this is one of my favorite topics actually. I wish I had my own data, but I will probably in 2025 sometime, I will present my own data. I have done about 200 hysteroscopies just for postmenopausal bleeding since the time I joined, 2010 onwards in Sitaram Bhartiya. And out of these 200 hysteroscopies, I have got only 4 cancers. And these are all the patients I'm talking to, which I have done myself. I have the video recording of almost every patient in my hard drive. So I had 4 cancers and there were 2 patients with atypia. And rest were all benign. But among the benign, what I would like to stress here, that unlike the premenopausal, in the postmenopausal patients, if you find a thick endometrium, anything more than 6 or 7 millimeters, whether she presents with bleeding or whether she presents with a thick endometrium just on a routine incidental scan, you find thick endometrium, almost 70% have a polyp. So I don't know whether it's a racial difference, but I find that atrophy comes second to polyps, particularly in postmenopausal, not in the premenopausal. So that is how I will just show you a few clips of patients. These are all postmenopausal patients. So this is a patient where the cervix is also stenosed. So instead of putting a dilator, you could actually use your hysteroscope, which is also a metal instrument. And if you go slowly under vision, in fact, you can go inside most of the time without causing much bleeding. In fact, one passage of a dilator might make it more messy, because once you get inside, you get a virgin view. So you see, I mean, there's no doubt that there's no shred of endometrium. So leave alone cancer, there's no endometrium. So I always tell patients, you know, that I can almost write on a stamp paper and give you a certificate that you don't have cancer. The interesting part here was that why it was reported as thick endometrium on ultrasound, because she had this septum, which obviously never gave her any trouble, but in the postmenopausal period, it actually became sort of got measured as thick endometrium. So, okay, so this is another postmenopausal patient, 68 years old, was sent to me in AIMS from the OPD because they could not hold her cervix to do a sampling. So now you see, in fact, I feel the gold standard, if you have the facility, is to put in a scope in all postmenopausal patients. It takes 5 minutes, but believe me, seeing is believing. Once you have seen this uterus, you are absolutely sure in your mind. Otherwise, you also keep thinking, maybe I'm missing a cancer. So you know there is complete atrophy. There is no endometrium. These are little specks of blood from where the bleeding has occurred. And like I said, polyps are very, very common in postmenopausal, because I think this is my theory, that probably some follicle grows and produces some estrogen, and there's a localized growth of estrogen, a localized growth of endometrium, which becomes a polyp. So this is again a patient with multiple polyps, but if you see, the rest of the endometrium is atrophic. So you still don't need to go ahead and do hysterectomy, because most of these are benign. This is another polyp. So this is, again, you see, you go inside. Now you see, the rest of the wall is completely atrophic. It's just these polyps, and you remove these polyps and she's sorted. You don't need to do anything more for her. And these are malignant polyps. So I had 4 patients with cancer, 3 had malignant polyps. And now with these 3, I really feel that I know what to look for and what I can call malignancy. Earlier, I was never sure. I used to say only histopath will tell. But after these 3, because all these 3 are identical, you always see this necrotic area on the polyp when they are reported as malignancy. And it is in all 3 cases the same. So I will show you the next, because there's nothing more to see. This is just the top, that whitish necrotic area is what is the hallmark of cancer. And when you do polypectomy, you know, it sort of tears off. It doesn't cut, you know, like you see, cancer is friable when you do open surgery. So you don't need to cut it. You put like a loop and it just tears off, you know, it is so friable. And this is another one with malignancy. Let me take it a little fast forward. I don't know how I'm doing time-wise. And you can go in vaginoscopic, so you don't need to hold anything. Now you see, again, very necrotic. So both of these were endometrioid carcinomas. You can see this necrotic area here, here, and little bit on the anterior wall. So this is now, I know, is typically cancer. Of course, look at the blood vessels. The blood vessels, sometimes you see big blood vessels and still the report doesn't come as cancer, but this necrotic tissue is very, very significant. It is cancer. So how do they present? They can either present with an episode of bleeding or spotting, or very common, particularly in metros where people are, a lot of people are literate and they do routine ultrasounds and they find that on a routine scan, the report shows thickened endometrium and they will come to you for consultation. So these are the two variety of patients that we get in the postmenopause. So the question always arises, how thick is too thick and when should we be intervening invasively, which means when should we be doing endometrial biopsy. So in this study, postmenopausal women with bleeding, the risk of cancer was 7.3% approximately, so that's a rounded figure, if ET was more than 5 mm. And it was less than 1% if ET was less than 5 mm. That is for postmenopausal bleeding, women with bleeding. What about postmenopausal without bleeding? So there are quite a few studies nowadays where people have worked out that you do not need to intervene or you do not need to do endometrial sampling at this 5 mm cutoff in women who do not have any bleeding and who just come with an incidental thickening of the endometrium on scan. So this study also, on the basis of their own data, they took this cutoff as 11 mm and they showed that the risk of cancer was 6.7% when the ET was more than 11, which is almost similar to the patient with bleeding with ET more than 5. And it was less than 1%, in fact, very less if ET was less than 11 mm. So what they said that below this, you don't need to always do a sampling. So at 11 mm threshold, there was another data besides the risk of cancer, depending on the ET, was that 11 millimeter threshold, the risk of cancer varied with age. So they showed that age 50, the risk was 4%, but by the time the patient became almost 80, the risk became 9.3%. So even at this threshold, the age needs to be considered as one of the high risk factors. What about recurrent postmenopausal bleeding? In fact, yesterday only I was doing a laparoscopy in Sitaram Bharti and one of the associate consultants, they said, ma'am, how can you just leave a patient when she keeps coming back with bleeding, postmenopausal bleeding? You will do a hysterectomy. So I told her that you please tune in today and let us hear, what is the data say. So this was a patient, this was a study on recurrent postmenopausal bleeding. And this was done in different centers in Netherlands. 437 women who had an episode of bleeding postmenopausal were followed up for 5 years further. And they found that 26% had recurrent episodes of bleeding. The study concluded that incidence of cancer was less compared to single episodes. So when women were actually evaluated for the single first episode, the risk of cancer was 17%, whereas evaluated for recurrent So, well, you do an ultrasound